Hello, good evening. My name is Chris Lamb. I am a fellow in the Peripheral Nerve Disorders Clinic at Mayo Clinic, and I'm happy to present the Charterhouse lecture this evening on peripheral neuropathy, the basics. And this is the basics. So for those of you who have some health literacy and are familiar with neuropathies in the audience, you may find this too basic, but I've tried to provide some very background information for people who do not have any medical experience. And I tried to phrase some of what I'm going over here as I would if I were talking to one of my patients in the clinic about their neuropathy. When you hear someone say, "I have peripheral neuropathy," what does that make you think? Well, this evening I would hope to define that term more clearly in your mind so that when you hear someone say they have a peripheral neuropathy, or if you yourself have been told you have a peripheral neuropathy, you would have a better understanding of that. That would include reviewing the common causes, symptoms, and signs of peripheral neuropathy, and a basic overview of some of the advances in the scientific work done at Mayo Clinic in the field of peripheral neuropathy. Starting with the basic outline of the nervous system, to know what the word peripheral means, we must first start with the central nervous system, which is the brain, brainstem, and spinal cord. This organ and the spinal cord that follows from it is considered to be central, whereas all of the nerves exiting from the brain and spinal cord are considered to be peripheral. And so when someone is talking about a peripheral neuropathy, they are not talking about a brain, brainstem, or spinal cord problem. They are talking about problems with all of the nerves exiting from and connecting to the brain, brainstem, and spinal cord. These include the ones in the face, the ones in the neck, trunk, and legs, and all of the functions of those nerves, which are moving, sensing, and doing automatic actions. Here is a map, schematic, of the peripheral nervous system as it exits the spinal cord, which you can see in the center of the frame. You see all these roots exiting out to the one side or the other. These roots form together and form into nerves that would travel down into an arm or a leg. So the medical definition of a peripheral neuropathy is probably a bit broader than how you have heard it or used it conversationally. And what it really means in medical terminology is any problem of a nerve or nerves. Neuropathy, neuro meaning nerve, pathy meaning problem. But when people say peripheral neuropathy, what you're probably thinking about is weakness, numbness, tingling, burning, or stinging of the feet and hands. And this is what medically we would call a polyneuropathy, a problem of many of the nerves. And generally speaking, the most commonly recognized pattern of neuropathy is what's called a length-dependent pattern. And so this is where the toes may be affected first because they come from the longest nerves. And so when people complain about their feet, they may have a polyneuropathy. Peripheral neuropathies are conditions that arise from damage to or dysfunction of peripheral nerves anywhere, however, and there are more than 8,000 known causes of neuropathy. Each individual cause may affect the nerves differently, or different groups of nerves. Each nerve is separated by its function and its location. And so some neuropathies are focal, meaning, for instance, carpal tunnel syndrome, where there is compression of the median nerve at the wrist. Some neuropathies only affect the sensing nerves, causing numbness or tingling, but no weakness. some neuropathies only affect the motor nerves, causing weakness without other symptoms. But most neuropathies do cause a mixture of these things. The nerves themselves are mixed together, but they serve different purposes. Some nerves carry signals from the body to the brain. Examples are the sensory nerves. When a person is touched, if you shake someone's hand, then that nerve signal is carried from the hand through the arm, through the neck, and into the spinal cord and brain. That nerve that sensed that is considered an afferent nerve. An efferent nerve is a nerve that carries a signal from the brain to the body, so when you are shaking a hand, how hard you squeeze it is carried down as a signal into your hand that squeezes the other hand. Every spot on your body is covered by a sensory nerve, and this is a map of the dermatomes, the areas of different nerves covering and supplying sensation to your body, and how they exit and enter the spinal cord. So this is a map of the sensory dermatomes, which means that if you touch your foot here, you may not be able to read, but that says L5. So when you touch your foot there, that signal must be communicated through the L5 root in the spinal cord, and then must travel up to the brain. Here are anatomic maps of the nerves, and you can see how complex these nerves are. They're mixing around in the arms and in the legs. You also notice that they are larger in caliber at the base where they come out and go into the spinal cord, and they are narrower or smaller in caliber toward the fingertips and toward the toes as they get further distant from the brain and spinal cord. Just imagine how long a nerve must be to start in the spine here and then travel all the way down your leg and into your foot. Each nerve cell has a wire that is that length. And what do these nerve cells look like? Well, the nerves themselves, if you examine them microscopically, are composed of three areas. The nerve trunks are surrounded by epineurium, which is a layer of connective tissue that protects each nerve fascicle. And the perineurium further separates the epineurium and nerve and the bloodstream from the nerve environment, or the endoneurial environment. This boundary is very important to protect the nerve environment from certain circulating toxins and inflammatory reactions, and when there is a breakdown of this perineurium, there can be disease of the nerve. And then each individual nerve cell, as I mentioned, the wire that is connecting from your spine into your fingertips, into your toes, and everywhere else in your body, is this wire represented here coming out of the perineurium, and we call this an axon. Now this axon is surrounded by a layer called myelin. The myelin acts like insulation around a telephone wire. If you imagine a telephone wire, there's an inner copper piece and there's an outer rubber or plastic insulator. And we have the same sort of structure in our nerves, where little tiny Schwann cells stack up along the length of an axon, which is the wire, and insulate it. And each Schwann cell here gives a little bit of myelin, and that helps to make the signal faster, and it helps to make sure the signal is not lost and degraded over the course of the distance of this nerve. You'll also notice that because there are individual Schwann cells stacking up on one axon, that where they meet there's a bit of a gap, and this gap was noticed by a neurologist named Ranvier, who called this the node of Ranvier. At Mayo Clinic, we look at nerves under the microscope, and this is what we see. These are the composition of nerve fibers in cross sections. So rather than looking down the length of a nerve, now we have split it and we're looking directly down the barrel. And this inner red area is the axon, and the outer dark circle surrounding it is the myelin sheath, the insulation that goes around that axon. Each nerve fiber, based on the caliber, has a different purpose, and the large myelinated fibers function to help sense vibration, joint position, and touch, and they also help to move the muscles. The small myelinated fibers and unmyelinated fibers, which you can see here, they almost look like little soap bubbles in this picture. They function to communicate pain and temperature sense, and other functions like autonomic functions, which include sweating. The manifestations of peripheral neuropathy might be a little different for everyone who has a peripheral neuropathy, and differ depending on the cause and the type of peripheral neuropathy. Typically, neuropathies are noticed because they cause some amount of weakness, which is the inability to move a muscle, numbness, which is the inability to feel a touch or sensation, or pain, or an autonomic problem. And an autonomic problem could be fainting, nausea, vomiting, diarrhea, constipation, alteration in sweating, and sexual dysfunction. Neuropathies that affect those large caliber fibers cause weakness because, as I said before, those large fibers are mostly going to muscles. They might also have difficulty walking because they cannot sense where their feet are. Patients with small fiber neuropathies have pain, sweating loss, or autonomic problems. As I mentioned before, the most commonly recognized pattern of neuropathy is what is called length dependent, which means that the feet are affected first and most severely, and gradually, if the neuropathy spreads, which it may not, it can spread up the legs to about the level of the mid-shin and then to the level of the knee. And once it reaches the level of the knee, that is about the same length as the fibers going to the hand, and so it may start to affect the hand also. But there are many other types of neuropathies. Length-dependent neuropathy is not the only type, and there are non-length-dependent neuropathies such as a polyradiculoneuropathy, which means that all of the nerves are being affected along the entire course, no matter what length of the nerve. And so this would cause someone to have weakness, numbness, and pain in the hips and shoulders in addition to the hands and feet. We also segregate neuropathies by what they are affecting, and some neuropathies affect that inner wire, the axon. For patients with axonal neuropathies, the nerve recovery potential is limited because the axon can regrow, but it needs to regrow within a tube. It needs a little track to regrow in, and if it doesn't have that track, then it is much less likely to succeed when it is regrowing. But if a neuropathy is caused by demyelination, if the neuropathy problem is focused on the insulating wire around the axon, then the axons are relatively preserved, but they just may not be conducting very well because they have lost their insulation. And so in this case, the treatment is directed on stopping whatever it is that is demyelinating the nerve, and hopefully, in many cases, the nerve can regrow as long as there is a track for it to regrow in. We evaluate peripheral neuropathies with several different tests at Mayo Clinic. These would include nerve conduction studies, electromyography, and quantitative sensory examination, as well as autonomic reflex screen, thermoregulatory sweat test, and nerve biopsies, and I'll go through these individually. Nerve conduction studies are a technique used to shock or zap a nerve and then measure where the electricity comes out, how much of it comes out, and how fast does it get there. And that tells us a lot about the integrity and contiguity of a nerve. So you can see in this picture there's a man here who is doing a nerve conduction study on a woman's hand, the wrist, specifically the median nerve, which is the nerve that is compressed in carpal tunnel syndrome. And so by zapping or shocking the nerve, putting electricity into the nerve below the wrist, and then measuring somewhere in the hand, we can measure across that area of compression if the signal is being slowed down or if the signal is being lost because of any compression at the wrist. Nerve conduction studies were pioneered here at Mayo Clinic by a physician named Ed Lambert and many others in and outside of Mayo Clinic. This test is often combined with electromyography, which is where there are no shocks or zaps performed, but an examiner would put a needle into a muscle and listen to the electrical signals in that muscle like a microphone. This would give us information about the severity of the neuropathy, the location of the neuropathy, which nerves are being affected, the time course of the neuropathy, and many other factors which are helpful to examine these. We also perform quantitative sensory testing at Mayo Clinic, which was invented and developed by Peter Dick. And in these pictures you can see the older machines that were used to test someone's foot sensation on the bottom right with heat and cooling, on the left with touch pressure. And these instruments have become more modern over time and slightly smaller, so we do have a smaller one now that can be used to sense touch pressure of the hand and heating and cooling of the hand, which tells us how different populations of nerve fibers are working for a person. We also perform thermoregulatory sweat tests at Mayo Clinic, which were invented and developed here. And this gives us an idea about the sweating pattern over the entire body. So you can see in the top right picture a person who has a typical length-dependent or distal neuropathy, where you can see all that is purple is where that person has sweat after being in a hot cabinet tuned up to 101 degrees Fahrenheit and painted with a dye, a yellow dye. When that yellow dye gets wet, it becomes purple, and so where it does not get wet, it stays yellow. And so you can see that this person has a length-dependent neuropathy that affects the legs more than anywhere else where they are sweating normally. But there are other types of neuropathies, as I mentioned, beside that, and you can see some good example of those on the other slides here. A person with a multifocal neuropathy, a neuropathy that is affecting asymmetrically one leg. That could be seen in some types of neuropathies. Or a person that has lost some amount of sweating over the chest region and over the legs, and so forth. This is the current thermoregulatory sweat testing cabinet that I mentioned, and a person would get covered in the yellow dye and then enter this cabinet, and they will sweat after the temperature is increased, and then we'll take pictures. This is a real example of a real patient who has had a sweat test, and you can see here that mostly the patient is not sweating very well, that there's a lot of yellow over the entire surface of the body, but you'll also notice these spots over the forehead, over the torso and arms, legs, and feet. And these spots are tiny regions of sweating that are preserved. And so this is an example of an autonomic neuropathy that causes what we call islands of sweat to remain, and it could represent a problem of the autonomic ganglia, or the sweat ganglia. So now that you know more about the types of neuropathy, the patterns of neuropathy, I will go through some of the most common causes of neuropathy. And in this part of the world, diabetes has been recognized as the most common cause in the Western world. Now, this may just be because it is easy to recognize, and other types of neuropathies that are more common may be unrecognized, and we will talk about that in a moment. But it is very common, and diabetes does commonly cause a polyneuropathy, which means the problems of the feet and toes, length dependent, but it also causes other types of neuropathy, such as a diabetic radiculoplexus neuropathy, which is a rare but is a form of diabetic neuropathy due to an immune attack on the nerve, and it can be treated with immunosuppression, whereas diabetic polyneuropathy does not improve with immunosuppression. Other examples of metabolic diseases besides diabetes that can cause neuropathy would include thyroid disease. Better management of diabetes has decreased the amount of diabetic symmetric polyneuropathy. That's what DSPN stands for. Prevalence of diabetes and complications in the United States are common. Greater than 1 million persons have type 1 diabetes. 15 to 20 million, and probably more, have type 2 diabetes. 50 to 60% meet minimal criteria for a diabetic polyneuropathy, which means that perhaps they have a bit of numbness in their toes or a bit of tingling in their toes, but they get on with their lives just fine, even though they have a little bit of a neuropathy. But rarely, less than 10% of the time in patients with diabetes, there are more problematic degrees of neuropathy, which might include weakness, imbalance, falling, numbness, tingling, foot ulcers, or other problems with the neuropathy. And much of our understanding of diabetic neuropathies has come from the Rochester Diabetic Neuropathy Study, which was organized and run by Peter Dick. James Dick, Peter Dick's son, also investigated the type of neuropathy called diabetic lumbosacral radiculoplexus neuropathy at Mayo Clinic, and found that it was an immune attack against the microscopic blood vessels in a nerve, and when those blood vessels are attacked, they stop supplying blood to the nerve, and then the nerve partially dies, and that causes pain and then weakness, usually in a thigh and in the distal leg, and it is usually asymmetrical, starting on one leg, and may spread to the other leg and then involve the hands. This is a microscopic picture of the immune system attacking these microscopic blood vessels in the nerve. And so you can see all these tiny dots surrounding blood vessels are evidence of inflammatory attack there. And this blood vessel, which you can see has a nice circular appearance in the top panel, has been fragmented in the middle panel by the immune cells attacking it and busting up those blood vessels. Other common causes of peripheral polyneuropathy would be an abnormal protein found in the blood, which is called paraproteinemia, and this sometimes causes a peripheral neuropathy. You may have heard of monoclonal gammopathy of uncertain significance, or MGUS, which can sometimes evolve into multiple myeloma in rare instances, but as many as 13% of people age 60 or older have some amount of monoclonal protein circulating in their blood, but only a very small portion go from this uncertain significance protein into a cancerous process like multiple myeloma, which is a blood cell cancer of the plasma cells. Many have similar symptoms to diabetic polyneuropathy. And much of the work on the epidemiology of monoclonal proteins in the blood has been done here at Mayo Clinic by our group in hematology and oncology. This is very important work that is evolving. I think that one of the most frequent but unrecognized causes of neuropathy are inherited or genetic neuropathies. And that is because sometimes the family history is not obvious. Maybe your mom or dad had a bit of numbness or tingling in the toes, and they went about their life. Maybe they were a farmer. They just got the job done for the day and they went home. They didn't complain. They didn't go to their doctor about it. And so nobody knows in their family that they had a neuropathy. But then one of their descendants, their children, might develop a different form of neuropathy, or more severe form, or more noticeable form. And so they start to have symptoms of neuropathy but don't recognize that their parents may have had them all along. And they can start later in life. One of the most important clues to inherited neuropathies are foot deformities. Patients can have high arches, skinny ankles, and hammer toes. So let me show you a picture of what I mean by that. This is a man who came to see us with an inherited peripheral neuropathy, and he has a very exaggerated example of a very high arch. You can see here that the arch is very high. He has hammer toes, which means his toes come up and then come down. And he has very skinny ankles that almost look like an inverted champagne bottle. Now, sometimes the changes are a bit more subtle than are pictured here, but this is an example to show you. These inherited peripheral neuropathies are known commonly as Charcot-Marie Tooth disease, which are the names of 3 neurologists that helped describe families that had neuropathies in the family. But there are many forms of inherited neuropathy, and some of them are mostly motor, affecting the muscles, some of them mostly sensory, some of them mostly autonomic neuropathies. So most inherited neuropathies, unfortunately at this time, do not have a specific treatment, which means we help people if they have pain or they have weakness or balance problems, but there's nothing we can do to reverse the neuropathy. But in the next 5 to 10 years, that may be changing. Dr. Peter Dick, the Mayo Clinic physician responsible for opening the Peripheral Nerve Laboratory and doing several of the important studies that I've previously mentioned, described 2 types of Charcot-Marie Tooth disease. Type 1, demyelinating types, which he described based on their slowed conduction velocity on nerve conduction study. When they give a shock or zap, the nerve transmission was much slower. And when looking at their nerves under the microscope, they had a problem of the myelin wrapping, the insulation surrounding their nerves. Whereas he called type 2 patients who had preserved conduction velocities, but weakness nonetheless, and decreased amplitude of the nerve conduction responses. And under the microscope, these looked like axonal loss of those inner copper wires. Now there are many different forms and genes known to cause Charcot-Marie Tooth disease, but we still use the Peter Dick classification, type 1 and type 2. So here is a picture of 2 brothers that have Charcot-Marie Tooth disease type 1A. You can see how similar their feet are, with higher arch in both cases. They have a bit of hammer toes, and they have very skinny legs and ankles, and otherwise they are very skinny together. Now some people might find the foot deformities of neuropathy to actually be beautiful. And this is an example of a published image from work done at Mayo Clinic. The famous painter Diego Rivera, met with a woman and painted her because he told her that she had the most beautiful feet he'd ever seen, and so he asked her to pose barefoot for this photo. And you can see in the photo she has sort of a flat arch. She has these slender toes that are poking up. And over 50 years later, after this picture was painted, she came to Mayo Clinic for her neuropathy because she had developed pain and other neuropathy symptoms. And so she was diagnosed with a hereditary neuropathy, which neither she nor Diego Rivera knew she had. Other causes of peripheral neuropathies include infections, which are less common in the United States but still somewhat common around the world. These could include syphilis or leprosy, which is a biblical disease but is still one of the most common causes of neuropathy in the world. It would also include Lyme disease, which is rare in this part of the country but is more common in the Northeast. HIV, herpes zoster, and hepatitis C. Here's a picture, a photomicrograph, of the leprosy organism inside of a nerve, and you can see these red organisms that are staining. Other types of peripheral neuropathy would include an autoimmune, post-infectious, or inflammatory attack against the nerves, and sometimes these attack the myelin. In the case of Guillain-Barré syndrome, they are very sudden and can be very severe, causing paralysis that ascends from the feet into the legs and into the arms and even the breathing muscles, requiring someone to be hospitalized and sometimes go into the ICU. The good news about Guillain-Barré syndrome is that many people who have had it make a nearly complete or complete recovery if they are able to be supported during the time that they have their illness. Chronic inflammatory demyelinating polyneuropathy is a more slow-burning immune attack against nerves than Guillain-Barré syndrome, and it evolves over at least 8 weeks by definition, and sometimes is progressive or is more of an episodic, relapsing and remitting neuropathy, which causes weakness and lack of feeling or numbness, but most classically does not cause pain at all. And this has been found to be a treatable form of neuropathy, initially by Peter Dick, who described the condition in 1975, and also described several trials of treatment which have been are still used as the standard of care today, including plasma exchange, steroids, and IVIG. Another form of autoimmune attack against nerves are necrotizing vasculitis, which would be an immune attack against the blood vessels in the nerves, like the one I showed you earlier with diabetes, except these may occur where there is no diabetes and instead another type of autoimmune disorder like lupus, for instance. So this is the initial publication by Peter Dick about chronic inflammatory polyradicular neuropathy in 1975 in the Mayo Clinic Proceedings Journal. And he described several patients, 53 patients, who were followed over about 8 years, who had weakness and improved with treatment of their immune system, immune therapy. Another common type of peripheral neuropathy across the world are malnutrition and vitamin deficiencies. And you can see on the right-hand side of this slide that there's a man here who has a lot of weakness in his legs. He has foot deformities from all the muscle loss in his legs. And he has a thiamine deficiency, which is called beriberi. And in this part of the world, in the United States and in Western countries, we add thiamine to all of our breads and foods. This is the meaning of fortified bread, fortified grain, fortified flour. So we don't really see this vitamin deficiency syndrome anymore, but in patients who are less fortunate, do not have the resources of the Western world, they may develop this vitamin deficiency. But also, we are so fortunate in this country that there's a lot of food around and many people become obese, and so then we undergo weight reduction surgery or bariatric surgery. And ironically, this can also lead to a neuropathy from malnutrition, because when bariatric surgery is performed, it is usually shortening the gut or decreasing the ability to absorb nutrients in some form or fashion. And so a similar picture can emerge if there has been a bariatric surgery. Alcoholism probably causes a neuropathy, but this is probably mediated through vitamin deficiencies and malnutrition rather than the alcohol itself. A study of peripheral neuropathy after bariatric surgery was performed here at Mayo Clinic by Dr. James Dick and by Dr. Parawat-Taisada-Watkal, and they found that many different types of neuropathies emerge after bariatric surgery. Even if there is no vitamin deficiency that is measured, sometimes there is an immune attack against the nerve which causes a microvasculitis. Toxic neuropathies are an important cause of neuropathy, and many chemotherapy drugs that are used to treat all sorts of cancers are neurotoxic and can cause a neuropathy, which can be painful. Some types of industrial or household chemicals are neurotoxic, but these are far more rare than the other types of toxic neuropathies. And some other medications besides chemotherapy can be toxic to nerves. So for the management, what do we do to help people with peripheral neuropathy? At this point, we do not have a medicine that regrows the nerves any better than the nerves are at healing themselves. So what we try to do is support the nerve function and allow the nerves to heal. But there is a study ongoing right now at Mayo Clinic. It is not enrolling new patients, but it is currently ongoing, being organized by Dr. Anthony Windebank, that is looking at placing scaffolding material into an area where a nerve has been cut or injured and seeing if that scaffolding material provides an adequate structure for the nerve to regrow itself. And this is an exciting project that may help people that have, particularly who have traumatic injuries where a nerve is cut or severed, that may help them to regrow it. The treatment of peripheral neuropathies otherwise depends on the type of the neuropathy and what is causing the neuropathy. If there is an autoimmune cause, then we may use immune therapies to alter the function of the immune system to stop the attack on nerves. If diabetes is the cause, then we work as a team to help patients control their diabetes with medications. This, of course, does not cure the neuropathy, but it would hopefully prevent further damage, and it would allow time for nerves to heal. And I often give the analogy of a firefighter to my patients, that we are like firefighters and we try to come to the scene of smoke and fire, which represents the neuropathy, and we come with our fire hoses and we try to put out that fire, whatever it is that is causing the neuropathy. We try to put a stop to that. But that is not the same as rebuilding the house, and that takes much more time in many cases. We also use medications to help with the symptoms such as pain and imbalance of neuropathy. So, in summary, peripheral neuropathies are very common problems, more than 1% of the population. It is estimated that greater than 6% of people over the age of 65 have a peripheral neuropathy of some kind. Proper evaluation of peripheral neuropathies is important to provide appropriate treatment and prognosis, and so that means seeking medical attention if you feel the symptoms of neuropathy, such as numbness, weakness, tingling, or burning. There are many causes for neuropathy, and even with advanced testing, including genetic testing, we may not find the cause of the neuropathy, even up to a third of the time, depending on the type of neuropathy that we are seeing. Treatment of peripheral neuropathy is directed toward the cause if it is identified and the symptoms. Thank you very much. I'd like to acknowledge Dr. Peter Dick, who I mentioned several times throughout the lecture. He is the founder of the Peripheral Nerve Laboratory at Mayo Clinic and has published many important works that have furthered our understanding in neuropathy. And much of what I have explained about neuropathy, about the, quote, basics of neuropathy, are insights that he has brought to us through his career. I'd also like to acknowledge his son, Dr. James Dick, who's my personal mentor, who's the director of the Peripheral Nerve Fellowship now, and who is currently the head of the Peripheral Nerve Laboratory. And lastly, I'd like to acknowledge Janine Ingolstad. She is a nerve technician that has been working for Mayo Clinic in the Peripheral Nerve Lab for more than 30 years. She takes photographs of biopsies and spreads them across the world. And so much of what the world sees in nerve biopsies and what they understand of nerves pictorially comes through Janine in the Peripheral Nerve Lab. So this concludes the presentation. If you do have any questions, you can pass those along to the organizers of this event and they will get those to me. Thank you very much and have a pleasant day.